You know what the number one predictor, even higher than smoking, of your longevity is your socialization. It's
Okay.
having people around you, people who you do things with, and purpose. So,
Yeah. Yeah.
if you look at I'm actually giving a lecture next week on purpose at this lecture at this conference, and it's very interesting when you look at people when they retire, their likelihood of dying for every year of retirement goes up substantially. And and I get people are all excited to retire, but the key is when you've lost some purpose, then there's something that goes on in our body that sort of says, you're kind of done, right? So our brain and our body connection. So you really have to have a social group of people, and you have to continue to have purpose, because those actually go above everything we just talked about in terms of longevity.
This week, I interviewed double board certified physician in physical medicine rehab and anti-aging and regenerative medicine, Dr. Elizabeth Yurth. Dr. Yurth has more than 30 years of clinical experience and continues to stay at the forefront of orthopedics, cellular, and regenerative medicine. We discuss the problem with modern-day orthopedics, along with how to halt the progression of arthritis, the importance of balancing hormones, how Dr. Yurth repurposes prescription drugs, her favorite supplement stack, and her one tip to get your body back to what it once was. Really enjoyed my interview with Dr. Yurth. I know you will too. Thanks so much for listening, and enjoy the show. All right, welcome to the Get Lean, Eat Clean podcast. My name is Brian Grin, and welcome to the show, Dr. Elizabeth Yurth.
Thank you, Brian, for inviting me.
Thanks for coming on. We met through Dylan Gemelli, who was on a podcast a few months ago. And glad to connect. You're out in Boulder. And
beautiful Boulder, Colorado.
Yeah, right. I think I'm heading out to Denver in a few months, so maybe I'll come out and check out. You have a longevity institute out there,
right? Boulder Longevity Institute.
And what year did you start that, and what made you what was the reasoning behind that?
So we actually opened this clinic about 20 years ago now. So we were kind of in this game a long time before most people were. My background's orthopedics. So I had a big orthopedic practice, doing well, busy orthopedic practice with a whole group of orthopedic surgeons. And really about 25 years ago, I started to get a little disillusioned, where I was like, geez, we kind of patch people together, but for some reason people never really get better, right? You would stick steroids in a knee, and then ultimately scope the knee, and then ultimately replace the knee, and then you'd move on to the next joint. And, people just kept falling apart. And so I started learning about how could I keep people from falling apart a little bit more, in terms of looking at their nutritional health and their exercise health and their hormonal health. Went back, and at that point, this whole longevity business was not like it is now. So American Academy of Anti-Aging Medicine, A4M, was one of the few places to kind of get fellowship training. So I went back and did fellowship training in more regenerative anti-aging medicine, and did some fellowship training in epigenetic medicine. And then I incorporated that into my orthopedic practice, which didn't go so well. It was like, you have 15-minute appointments, and you're trying to teach people about hormones and nutrition and exercise, and that doesn't work so well. And so we decided we would open Boulder Longevity Institute. So for a long time, I just wore both hats. I would by day do orthopedics through traditional, and then send people over to my longevity clinic, where I'd say, let's actually get you healthy here. So I would work all day doing orthopedics, and then change hats and go back and do longevity medicine in the evenings. Wow. And then really I did that for a lot of years. And, it's hard to give up what you've trained in for your whole life. So really it was only about 5 years ago that we just brought all the orthopedics into our longevity clinic. And so we do a lot of regenerative orthopedics here. We do a lot of, doing things to help joints regenerate, but have focused more on treating joints from a very different perspective. So 5 years ago, left the orthopedic practice. The sort of the straw that broke the camel's back was one of my partners. I was ordering some labs on a patient and going over the labs. And one of my partners, was sort of upset that I was actually doing this. He was like, we actually don't do medicine here. We do orthopedics. You need to stick to orthopedics. I thought, that doesn't really make sense. This obviously is not a good fit. So, And it was funny because I could, for a long time, our practice was smaller. It was when it grew with, more young partners and things like that, that people became a little bit more focused on, it's all about money. It's all about how fast we can see patients, how many
Right.
surgeries we can do. And that wasn't my focus. So leaving there and coming here full time. And now we've grown this into a huge institute that does a whole lot of things, from brain health to bone health to just longevity medicine. And it's been amazing.
Wow. Yeah, I give you credit. I mean, I think, it's like uh, old school meets new school a little bit, right? And sort of collided, and you went the more of, I would say, the new school route. What
Right.
would you say your approach to orthopedics is compared to what the like traditional old school approach is?
So the problem with the way we look at joint disease and spine disease, so we'll look at degenerative disc disease, degenerative joint disease, is it's always been sort of felt it's a wear and tear disease,
Hmm.
right? That we basically just wear out our joints. And so time is not our ally. The more exercise you do, the more you beat yourself up, the more you're going to wear out your joint. And that's actually as much a fallacy as saying the more you think your brain is going to degenerate, or the more your heart beats, the more it's going to degenerate. Our joints actually should not degenerate. So, what we've learned over time in this sort of more longevity field, not recognized in the orthopedic field, is that joint disease is not just wear and tear. Certainly, an injury can propagate inflammation, which can start you down this road, but it is an inflammatory disease process. So it's an injury where your body didn't heal it appropriately because you did not mount a normal inflammatory response.
Mm.
Just like what's happening in things like getting a virus, like COVID, right? That if when we develop long COVID, it's a adverse immune reaction to this virus. Well, the same thing happens if I have an injury and my body over attacks. It doesn't turn off the inflammation, then I will continue to degenerate. And then, we stick steroids in it. We do arthroscopic surgery on it. We do, joint replacement on it. But we don't really treat the underlying problem, was that your body was adversely treating the joint itself. So we now have learned when you look at degenerative joints and degenerative spines that those people have very abnormal inflammatory markers. That they have something that's called interleukin 1 beta that's very high in the synovial fluid of these joints.
Mm.
Interleukin 1 beta is a very bad inflammatory cytokine. It's also associated with cardiac disease, which is why people who have joint disease have much higher incidence of cardiac disease. We always believed that was just because maybe they exercised less. It's not. We now know it's actually a direct link to this abnormal inflammatory process. Now, some of that can be genetic, right? You may genetically have higher levels of these inflammatory markers, and some of it's environmental. Sometimes things we're doing will elevate these. So very high levels of things like interleukin 1 beta. And so we've never really focused on treating that. And then also very high levels of these degradative enzymes. So these enzymes that are designed to come in so you hurt yourself. The body's designed to mount an inflammatory response.
Sure.
So for a few days, we want these white cells to come in. We want the body to try and heal things. And we bring in these enzymes, and the enzymes are designed to sort of clean up the mess. So now I've got this debris, these dead white cells. So we have these enzymes that are designed to clean up the mess. So think about these little sort of Pac-Men. They're coming in to chew up all of the degradative products. What if those don't turn off? So if 3 days later, what should happen is I switch off this inflammatory phase and I start going into a healing phase. What happens to progress to an arthritic, worn out joint or worn out spine is that switch doesn't happen.
Mhm.
So these degradative enzymes, now it's a little bit like I'm scrubbing a spot on my wall, and I keep scrubbing and I keep scrubbing. Now there's no spot, but there's no wall either. So we know these high levels of these degradative enzymes play a role. We know these high levels of these inflammatory cytokines play a role. You can't treat that with surgery. In fact, what happens if I stick a knee scope in? I'm actually going to create ongoing more inflammation, which is why when you look at knee arthroscopy, which has been pretty much banned in every other country for doing things for if somebody tears a meniscus, you don't go in and scope it like we do here in the US, because the data shows that you actually markedly worsen the progression of arthritis when you go in and scope a knee. So, and yet it's a bread and butter surgery here. We do it on
Yeah.
everybody. You hurt your knee, the doctor goes, oh, let's go in there, we'll clean it up. which makes about as much sense as you going in with your demented mother and the doc says, let's cut out those bad parts of her brain. She'll be fine. So that's where we have to switch over our thinking. And number one, treat acute injuries very differently, where we allow inflammation to occur, not just blunt it as immediately. So what do people do when you hurt yourself? You ice, you take a bunch of anti-inflammatories, right? And you stop moving. Those are sort of the very worst things you could do in those first days of injury. It's been well documented in the mouse model that when you do those things, you actually don't amount the necessary inflammatory response to start the healing process, right? So the first 3 days, you don't want to be taking a lot of anti-inflammatories. You don't want to be icing. You just want to let some of the inflammation occur. Obviously, if you need something for pain, sometimes you have to do things with that. And you want to move as much as you can. It might not be that joint, but you want to move everything else. Every time I've had an injury, I'm back in the gym the next day. If I can't walk, I'll use my arms, right? But you want to keep moving because motion actually brings in some of these healing or these healing cytokines, proteins that help you heal. So for the first 3 days, we want to actually let inflammation go, and then we want to work on turning it off. So then you can begin more of an anti-inflammatory protocol. The very best thing is actually low-dose aspirin. So low-dose aspirin actually can be utilized because it turns something called a pro-resolving mediator, so an aspirin-mediated pro-resolving mediator pathway. So basically, we have these pro-resolving mediators. So at 3 days, we want to bring these guys in. They're the key to turning everything off. Pro-resolving means let's resolve the inflammation. So aspirin actually promotes that pathway. So when you looked at a mouse model, when they gave a mouse simply a low dose of aspirin, 3 days after an injury, they did not go on to develop chronic degeneration or chronic pain. So we have to rethink the acute injuries. So number one, let's treat those differently so that we actually don't start this cascade of events. And then in people like me, I've had 4 ACL tears, I've had rotator cuff tears, I have horrible knees, but no pain. And that's because what you need to do next is look at people like me who obviously have a propensity. I have a dad who had horrible arthritis, who have a propensity to degenerative joint disease, and say, okay, what's wrong with her? And then we work on stopping those things that are wrong. So blocking interleukin-1 beta, blocking these inflammatory degradative enzymes has to be top of the list of treating bad joints. So when you have somebody who comes in with an injury to their joint, first thing I'm going to do is help them treat that injury appropriately, and then I'm going to actually help look at their overall things. If this is now the 4th joint that's been painful to them, then we actually start them on things that work on these inflammatory processes. And our sort of favorite go-to there is a drug that's not, it got approved in Australia in 2019. It's called Zylosol. And it's in phase 3 trials here in the US, but not yet available. But the drug itself is something called pentosan polysulfate. Pentosan polysulfate is available just in oral form. So it's been around since 1985 in an oral form to treat bladder inflammation. So it's a widely tested, widely used drug. So it's already been safety tested. It's an FDA approved drug. The difference is Zylosol, which works for joints, needs to be done in an injectable form. So you have to do a little subcutaneous injection, not into the joint, just a little subcutaneous injection. We're trying to work systemically on people. So what we've done is we work with pharmacists that can take the drug, it's available, turn it into an injectable form on it, which we can use very tiny, tiny doses of, and stop this process. What pentosan does is it turns off interleukin-1 beta. It blocks these bad degradative enzymes. And the studies that have been done now out of Australia, Paradigm Pharmaceuticals makes this product, show that when you have somebody on this drug, after a year's period of time, they had 30% improvement in the joint space, almost 30% improvement. The other group who was not on it showed degradation of the joint, which is what we usually see, right? A year later, the joint's a little worse. A year later, a little worse than that. So we're halting and reversing the progression of arthritis with this drug. It's probably going to be a potential cure, maybe not complete cure, for osteoarthritis. And yet it's going to take a long time for it to get here to the US. It will get approval, and then we'll see what insurance does with it and things like that. But it will get approval. So we know that when you treat the inflammatory process, this disrupted process, that's the answer. Not scoping the knee, replacing the knee. So, because every time you do that, what have I done? My body is still systemically doing the same thing. It's producing high levels of these bad things, and my other joint goes. So if you look at somebody who had a knee replacement, and the next year the next knee goes, and the next year the hip goes, and the next year so how many people do you know have had both their hips replaced and both their knees replaced, right? So we are so looking at this the wrong way. But it's a hard industry to change. The total joint industry is financially great. There's a lot of money in it. There's, and I won't say that, if I have somebody who has horrendous joint disease or bone on bone, they have horrendous pain, joint replacement is a wonderful thing for them. My hope is we stop letting people get to that point.
Right. Yeah, I was going to say I don't know how much of millions of billions of dollars are made with joint replacements, but especially now, these baby boomers are getting to 75, 80, like my parents' age. My dad got his knee done. And I know a lot of people who have gotten these joint replacements. And I will say, from the people I talk to, it's a lot of mixed results.
Right. Right. Some people do great.
Yeah.
Some people not so well. Nobody will tell you I feel the same as I did before, right?
Yeah.
So hips are a little bit better. We've done a little bit better job with hips. But this to me is a little bit like if we took everybody with heart disease, right? And instead of actually screening for atherosclerosis and early heart disease, we just waited till everybody needed stents. We just didn't even, we're like, let's just keep an eye on you. Let's do nothing. Let's do nothing. Let's do nothing. We'll just put a stent in when you need it. And that's exactly what we're doing with joints, right? We're really not doing anything to keep that progression. We just go, well, this is just going to keep going, and then we'll replace it when you get old enough. And now we're seeing people get replacements in their 50s, right? We're seeing it at younger and younger ages. So we have to start looking back to what are we doing wrong from square one, which is treating the acute injuries, or looking at people who have kind of multi-joint problems as this is a disease. So those of, there are people who hurt their knee and get better and are fine. I have professional football players in my practice who, we were treating for concussions, but they have fine joints. That you have these people who really were sedentary most of their life and have worn out every joint. So it's not a disease that's related to your activity level.
I was going to ask you if you work with like football players and athletes at your practice.
Yeah, we definitely do. So we work with a lot of, both recreational athletes, college athletes, high-level athletes. It's funny because like we had a football player who came to us where he found out about penicillin himself because he had, horrible hip arthritis and he was young and he had no answers. I mean, basically the answer was, we'll scope your hip, which they did. They did twice, and he was 26 years old.
Wow.
And he already had hip arthritis, and he basically was looking at the end of his career, right, at 26.
Yeah.
And he self-researched and found out about penicillin, and he was like, "Oh my God, why can't we get this? Why can't we use this?" And they found out that we, that we do this. And so he came to us. So, but he was saying, he goes, the trainers don't know about this. He goes, I keep telling my friends about it. But why don't more people know about this? And, partly it's not widely available here yet. And so, but partly it's a little bit of changing this paradigm. And this is an entire field that I'm trying to disrupt. That doesn't go so well, right? Just like in my practice, they didn't want me disrupting the status quo. They're doing very well, right? There's a huge, there's orthopedic surgeons do quite well.
Yeah. I mean, I got to imagine trying to interrupt that sort of old school approach to some degree, right? There's a time and a need for it, but it's probably not so easy. Right. But I think what you're doing is just helping people who are, want to look beyond just that instant, let's just say that answer that most people are going to give you, and create your institute. And that's great. And right. I would say that like, what would you say to someone that's, I like for myself, for example, I mean, I'm in my 40s, but big golfer, repetitive sports, right, for a long time. What are the sort of best preventative ways to, not have to, go to and get surgery or, do things like that?
So number one, obviously, is, like when you look at golfers or you look at people who are very specific to their sports, right? If you're a cyclist, you cycle. If you're a runner, you run. There has to be a strength training program that is working on everything.
Right.
Because we tend to get, and especially some of these very focused high level athletes, right, are very focused on sport specific training. And that is not so great. We really need the entire body to be very balanced from the feet to your head, right? So all the postural mechanics, everything has to really be balanced. So there has to be a lot of attention paid to ongoing strength training. And one of the things you find as people get busy, like you look at you, right? It's hard enough to just find time to do things like I want to get out and practice my golf. I want to, and or my runners are going to run. That's what they do. They run. And you have to sort of say, listen, that's great. You love running, but you've got to change your focus a little bit to spend a little bit more time in the gym doing more weight training, doing more sport, not even sport specific training, but really just all over body training. So that's kind of the first thing, because I do think as time gets more limited, we get more limited, and so if we're trying to really run marathons, we're going to focus on running a marathon, and the problem with that is it doesn't bode well for your overall health when you're doing that. So number two is when we look at these age-related diseases, right? Arthritis is still an age-related disease. So you're like, well, why, if it's an inflammatory disease process, why are we seeing it, as people get older? And it's because, and it's because a large part of these inflammatory things going awry has to do when we start getting disruptions in hormones, right? So when you look, and we're seeing that, unfortunately, younger and younger, there's all these endocrine disruptors in the world. We are seeing testosterone levels in our 20-year-olds that we used to see in our 80-year-olds. We're seeing very few men now in their 50s who have normal testosterone at all. When you start losing hormones, testosterone for men and women, but also remember that men have all three hormones just like women do. And estrogen and progesterone are hugely joint protective. So progesterone, for instance, there's receptors on the joints. So one of the reasons you start to get stiffer as you get older is because there's less lubrication to the joints. And that's largely because of this drop in progesterone levels. And men, it's a forgotten hormone in men. Men have progesterone levels just like women do, much lower amounts, but just like women do. And estrogen keeps our joints more pliable, keeps our ligaments more pliable, makes us more stretchy. So basically, it's one of the reasons women tend to be more flexible than men, right? Is that we just have this hormone that makes our tissues a little bit more pliable so that we can have babies, our pelvis can expand. Well, men, when testosterone level drops, when for you guys, estrogen comes from testosterone. It's converted from testosterone, and there's an enzyme that converts it to estrogen. And it's equally important to have estrogen as testosterone. So the first thing the body does when your testosterone levels start to drop is it starts to forego converting it to estrogen. It would rather you have testosterone, and it worries a little bit less about estrogen for you. So what happens is you start to see testosterone levels decline just a little bit. So you might not be noticing things like, like your libido's still fine, you're still making muscle fine. But if you look at labs, you'll see that estrogen levels are like less than 10. They're really low. When that happens, one of the things that happens is our joints become less pliable, our tissues become less pliable, our brain becomes more dysfunctional, our heart becomes more dysfunctional, because estrogen is one of the main protectors of heart and brain and muscle. So basically, hormones need to be looked at early, and they need to be followed, and they need to be optimized. I mean, even somebody like you who's in your 40s, you're like, I'm fine. My hormones are going to be fine. Don't know, right? I will tell you, a lot of guys in their 40s don't have normal hormones. And you really want to be proactive that we keep those at a good normal level starting from when they start to decline, not wait until they're down here and then start treating, which is what we do, right? Because that's when all the destruction is occurring. So we're having all this loss, and then we're finally treating. In both women and men, our hormones are starting to drop in our 30s. I hate to say it, but in our 30s. And so keeping an eye on that, and when they start to get more critical levels, then actually giving some replacements of hormones is really important. It's critical to joint health. I will tell you, a small dose of progesterone, just using a little sort of a lozenge that people suck on before they go to bed at night. And for men, helps the prostate, helps hair, helps sleep, helps anxiety, helps joints. So things like that can be really proactive to keeping the joints from going away. And right now we're not doing that. Nobody would ever come in and think about, when their joints hurt, looking at hormone levels. And I always do. because that's one of the things that could play a huge role in such a simple fix. So that's one of the, so aside from keeping your really well-rounded training focus,
Right.
also making sure that hormones stay high. And obviously nutrition, protein deficiency still is huge. People don't eat enough protein, even with all the stuff people are hearing about protein. I mean, you really need a gram of protein for every pound of lean body mass, and that's hard to do. I mean, I'm skinny, so I weigh about 130 pounds. So it's, 130 grams of protein. And even for me, that's hard to do. But if I look at my, 24-year-old son who's, 190 pounds of muscle, he needs like 200 grams of protein. And so that's not easy. You have to really focus on protein-centric eating to be able to do that. But protein is so important for both muscle and joint health. So we have to make sure that people are getting enough protein, particularly as they get older, right? One of the things you see as people get older, they eat less and less protein, and they actually need more protein, especially women. I mean, women are really bad, right? But if you look at both men and women, as they start to get older, they're not going to eat as much, whether it's because you're concerned about weight or whatever. They're not going to eat as much, but or appetite decreases. So you really have to push that on people.
And going back to like the training correctly, because I do train clients at my house, and a lot of them are golfers. But like I see this with myself and a lot of golfers is they start losing thoracic mobility.
Yeah.
And,
that's huge, right?
Yeah. Because then
that's when people have shoulder injuries, people forget it probably started with loss of spine motion, right? And now the shoulder goes, and now the elbow goes, and
so they lead, one thing leads to the next. That and like hips, like making sure that you have mobility within those two.
Agree. And we don't work on mobility or flexibility training a lot, right? People aren't doing that much. But watch older men walk. They almost always walk with a little bit of flexion at their hips. If you watch a 60-year-old walk, they will always walk a little bit more tilted forward. And a lot of that's because they lose some of the extension ability of their hips. And if you're not doing, really focused work on mobility training, Sean McCain, who does a lot of talking, he's an ex-gymnast, talks about this a lot. He basically says, that you need to be focused in that as part of your regime. That basically that's got to be part of your training. Be it yoga, or if you hate yoga, but you've got to be doing flexibility training, because you're right. When you lose that motion in your hips, when you lose that motion in your spine, which is going to happen if you're not training it, then you're going to start getting more of these injuries.
Yeah.
So I love that you mentioned that.
Yeah. I would try to say if I have a client, that's probably 50% of the things that we work on. The other 50% is strength.
Yeah.
Yeah. And training hormones, obviously adequate protein. I would say that like, general practitioner is going to take basic, like I have a doctor that I go to just to go to, but like, I think it's important for people to have someone like yourself who has like some functional background regarding just like regenerative or aging medicine, but also just knows that like what's going on in the mainstream isn't telling you the complete picture of your health.
Right. Like your doc is going to look at basic lipid levels, CBC, CMP, thyroid, a very basic.
Not
thyroid,
even. I was gonna say I don't even think he ran a thyroid on me. I asked him actually. I'm like, because he knows that I'm into like alternative health. Like, I'm like, how about testosterone? He's like, well, you have a lot of muscle mass. I'm like,
right, yeah. And what's funny is, I do a lot of like I'm lecturing at the upcoming Mr. Olympia, so I do a lot of lecturing in kind of the bodybuilder world. We have this thing called Olympia University that occurs. And you guys who get into the bodybuilding world, if you go to Mr. Olympia, we try and host this Olympia University. And it was kind of designed
that's cool.
by a guy named Michael Polnieri that his goal was to say, okay, bodybuilders are sort of the original biohackers. They are great at it, but they don't always do it in a safe level. Right. So he brought together a lot of experts in the powerlifting, strength training fields, and basically does this sort of Olympia University.
When is that? Yeah, when is that?
So Olympia is like October 18th, which is really, if you've never been, Brian, you should go, because it's just like, even if you don't go to the competition, which is pricey, but just going and walking around the exhibit hall is number one, enormously educative, but also entertaining as heck. There's everything under the sun there,
Yeah, I'm
and every
sure.
person under the sun there. But so we do kind of the mornings. We do this Olympia University, and it just brings together these panels of experts in hormones um, and
Is that where you met
training.
Dylan? Is
And
that where you met Dylan?
I think that's where I met Dylan.
Yeah.
Yeah,
Okay.
with Olympia. Yeah, I think that's where Dylan and I first met was at Olympia University. Yeah, I
Oh.
think that's where we first met. So so
Uh,
it's a really for those of you guys who are kind of into that world at all. I take my whole family,
hmm.
and it's just it's really kind of a fun event.
Yeah.
So
Where's it
and
located? Where's it located
it's in
in?
Las Vegas,
Oh, okay. That's not in October, not the worst place to
October.
be.
Yeah,
Yeah.
yeah. But it's, and the exhibit halls, I mean, if you want to learn about nutrition and things like that, but we don't get enough people at Olympia University. It'd be nice if it was a little bit more widely publicized, but it is really, I think, one of the best, I lecture a lot. I do a lot of lecturing at a lot of different conferences, but it's kind of the best group of just practical knowledge people putting together
Mhm.
these. I mean, there's this one strength training coach who has basically trained all of uh, the strong men who have won. The strongman competition is a very
Oh,
you
yeah.
have to I mean, these guys have to be like timing perfectly to when their carbs kick in, when they're because they're
Yeah.
lifting one big, heavy, hugely heavy thing. But
Right.
he's trained all the main strong men, and he's brilliantly smart. It's just like you get this knowledge base that you don't really get in my medical field so much.
Hmm.
That puts together this practical and medical knowledge base together. So it's an interesting.
No, I'll definitely check that
You'd
out.
like it.
Yeah. Uh,
But yeah, I think that your push on not just strength and flexibility, I love that because I think I forget to mention it, and I even forget to talk to my patients about that mobility training is equally important. My husband is really stiff.
hmm.
I tell him all that you've got to get more flexible. We have to get your hips back.
I mean, I would say every night I do something like I have a little gym in my basement. I do something with like, just, my tissues, fascial stretching, or, whatever it is. And just a little bit adds up over time. Even if you do it 10
Right,
minutes a
right,
day, it's like
right.
makes a big difference.
Yeah, because we spend so much of our time sitting here in a flex position, right?
Sure.
Just sitting at
Yeah.
our computers, at our desks in this 90-degree flex position with our
It's funny.
shoulders
It's funny
forward.
you say it's funny you say that. I'm actually kneeling.
Yeah, great.
So
I
I'm
do.
in extension.
Yeah.
Yeah.
So I have a leaning chair, a treadmill under my desk. I've got
Okay.
a leaning chair, a treadmill, and a regular seat, and I just transfer from one position to another, right?
Right.
And actually kneeling is one of my more comfortable positions. It's like just easier on my back.
Hey everyone, quick interruption here. If you are looking to gain energy, lose inches around your waist, and build strength, well, look no further than my book, The Step Ladder System: 6 Steps to Lifelong Health and Vitality. What you get with the book is my full step-by-step plan and blueprint that I've worked with all my clients with, packed into one book. With part 1, you're going to lay the foundation, tackle any common challenges that might come in your way. Part 2 is my 6-pillar blueprint, how to set yourself up with a solid plan and know exactly what to do when life throws any curveballs. And lastly, step 3 are learning to implementation, a plan for getting results over the next weeks and beyond. So there you have it. I'll leave a link in the show notes for my Stepladder System book. Now back to the podcast. I've gone through a lot of pads. I have a new pad that I'm trying to kneel on, which has been a lot better than some of my other ones because, you just wear through them if I'm on my knees
So
all day.
is that what you have? Is it most of your time? Do you do it on your knees?
Yeah, like I have.
Wow. Yeah, that's great. I'll have to do that more.
Well, yeah, I have this desk and obviously I can't stand. It's not high enough. And so I could maybe down the road do a standing desk, but the kneeling was
Yeah, I
is
have one of the
big,
desks that goes up and down, so I
up
go
and
from
down.
all the different positions, right?
Um, yeah, so it works for me now. It's been working for the last few years. But you're right, like the positions that we're in, this sedentary, I mean, like sedentary positions or just like in sitting, rounded shoulders. I always say like with golf, why there's so many injuries? Well, I don't know. You're sitting in a golf cart, then you're getting up and swinging a club at whatever, 100
And
miles
then get
per
back in
hour.
your golf club.
Getting back, and don't get me wrong, there's a time and a place for a golf cart because I use them from time to time. But I just feel like if you can walk, you should walk. Like
Yeah.
it'll
It
be
makes a lot of sense, right? Keep moving so you don't stiffen up.
exactly. Yes. Gosh, we can go so many ways here. Why don't we touch a little bit on, I heard you talk about this in another interview, like the alternative sort of ways to use, like you even mentioned like Cialis or Viagra, where there's different purposes for some of these compounds that are
Right.
maybe, used for certain things, but it actually can help in other ways.
Yeah. So I do I do a lot of studying and researching on repurposing of drugs. And the
Mm,
reason that's so valuable is because there's this whole, people are anti-pharma, but pharmaceuticals have a lot of value in our world. They really do, right? Now, are they overused? Are they sometimes misused? Yes, but they have a lot of value. And so if I have a drug, it takes a lot to get FDA approval for a drug, right? So if I have a drug that's already been through all that, it's gone through all the testing. It's been around for a while, so its safety profile is well established, right? People have been taking it now for 20 years. So I have a drug that's like that. Now, if I can think about that drug's mechanism
mm,
and say, where else could I apply this, right? So if you look at, for instance, Cialis, do you think it's thought of it's for erection quality? Well, why? Well, because what it does is it brings blood flow to an area. Well, that's a pretty good thing, right?
right, right.
If I have more blood flow to my brain, if I have more blood flow to my extremities, I'm going to be healthier, the brain particularly.
Sure.
So if you take a low dose every day, all you're doing is you're improving your vascular function. You're improving the way the lining of your blood vessels. It's healthier. You pump blood better. And at a low dose, you don't walk around with an erection all day, anything like that. All it does is make you have better vascular quality. And that's really important because one of the things that happens, with age or with viruses, COVID was a big culprit here, is we get damage to the vascular lining. We get damage to what's called the endothelial lining, the very inside of our blood vessels. So that gets damaged. And that's one of the first steps to impeding blood flow. It's why, when we get older, we just don't have as good circulation. But it's what they found is the guys who took Cialis for having better
Yeah,
erections actually
sure.
had much less dementia. So that sort of started this road of,
Hmm.
wow, well, there's more going on here. So start really investigating it for cognitive decline and things like that. So we do a lot of using it, I would say, in both men and women,
Hmm.
that we use it a lot just for vascular function.
Hmm.
I think it's a great, these are what are called phosphodiesterase 5 inhibitors. And if you start looking at phosphodiesterase 5 inhibitors, they even are showing huge benefit in cancer prevention.
Hmm.
So these PD5, this pathway, the same pathway that's affecting erection quality and vascular, has a lot of other mechanisms. So that's what you have to do is you have to look at what does a drug do? Okay, it inhibits phosphodiesterase 5. What else does phosphodiesterase 5 do? And if I inhibit it, what other value am I getting? So this is a drug that can help prevent cancer, help prevent cognitive decline, help prevent cardiac dysfunction. 5 milligrams a day, no side effects. And it's huge. And yet, when we prescribe it to a woman and they go try and fill it at the pharmacist's like, what?
Hmm.
So, and there's other drugs like that. Telmisartan, for instance. Telmisartan is a blood pressure drug. So, but it's what's called an angiotensin receptor blocker. And when you look at its mechanism, it has huge longevity benefits. So it actually is a drug that's working on some pathways that are very pro longevity. So when they looked at people on telmisartan, they actually had less cancer, they lived longer. But the other big thing about it is it's a drug that helps endurance. So
Hmm.
it's what's called a PPAR gamma agonist. So it's used and it's actually banned in a lot of sports because so is tadalafil, because these are exercise performance enhancing drugs, right? Well, something that's an exercise performance enhancing drug probably has benefit for most of us for life, because life is really, if I sustain long haul exercise, then that's what I need to survive too. So when you
Sure.
look at telmisartan, it's a banned WADA drug. It's a banned WADA drug because it does influence something called PPAR gamma, which is something that when it's stimulated, we have better VO2 max, we have better endurance, we actually utilize oxygen better. So low dose will not affect blood pressure, but will give you these benefits for vascular function and for helping performance, endurance. So it's a really nice drug to add on to some people too. So a 20 milligram dose, which is not going to cause blood pressure changes, can be really beneficial. And then you have patients who have high blood pressure. You can go a little higher on it, and they're going to get the benefits as well as the blood pressure benefits. So there's another drug that, repurposed drug, Pentacin, another drug, right? We just spent all that time talking about Pentacin. Well, it's a drug for bladder inflammation. But what does it do? All those same things it's doing for bladder inflammation are beneficial for joint inflammation. So this is where it's kind of fun to be in a world where you start looking at, once you understand cellular pathways. So if I understand what's going awry in a pathway promoting a disease, I can now start looking for drugs that work on that pathway. And AI is huge here, right?
Sure.
Because you can run AI and go, okay, I need you to find every compound for me that works specifically in this place on this pathway. Right now with ChatGPT 5, which I don't know if you've used yet, it came out yesterday, it's hugely impressive. You can do so much of just saying, find me every compound. It'll give you a list, a massive list, but then you can start wheeling through it and saying, okay, this one's not available, this is not available. Now I want you to give me the ones that I can either buy at a drugstore or have a doctor prescribed, that are easy. So we're going to see, I think, more and more of this. But what it entails is a doctor who loves studying pathways, right? Because you better understand the pathways to be able to do this. But the whole repurposing of drugs is amazing. And for those of you guys who, just want a simple regimen to protect heart function, brain function, aging, tadalafil is a huge, I would say 90% of my patients are on it.
That's really interesting. And when you first started talking about this, I heard you on another podcast. One thing came to my mind was methylene blue, and I had, the name is escaping me, but I've had the EOCO of transcriptions.
Yeah, Scott Scher.
Yeah, Scott Scher. Yeah, and I've always thought that was an interesting compound that used to be used as a synthetic dye.
Right.
It's crazy. Now it's coming back, and maybe might support mitochondrial health and energy and things like that.
Right. So methylene blue will actually work on inside the mitochondria to actually sort of skip one of the steps to make ATP. I think you have to be cognizant with how to use methylene blue. It's not something you want to be using continuously because it can disturb nitric oxide pathways, but it can be a super useful drug to help boost mitochondrial function. When you have, like, if you're going to go out hiking in the mountains or, are doing some exercise.
Or traveling, or even traveling
or things like that. It can be hugely beneficial.
Yeah. Yeah, I've been using it I get it from him, and I've been using it from time to time, and just low dosage, and
right.
Other than the only thing to get used to is just peeing blue.
Peeing blue, yeah. I know. A little bit of shock the first time you pee, and you're like,
yeah. Still sometimes now I'll be like, oh yeah, okay, that's fine. Yeah, look like other than that, yeah, it's that's what came to my mind. Also, like aspirin. I don't know if you're familiar with Dr. He's a doctor, but Georgi Dinkoff. Are you familiar with Georgi Dinkoff? Yeah. Okay. Go ahead. I've had him on a few times, and I know Dr. Ray Peat talked about the uses of aspirin and how it can be of benefit in many different ways.
Right, and we just talked about one. This aspirin-mediated this specialized pro-resolving mediators are very cool. They come from all of our omegas. So it's one of the reasons omegas are so important. So your DPAs, your DHAs, and your EPAs, one of the things they get turned into are specialized pro-resolving mediators. And these are things called resolvins and I forgot all the names, but that's one of the conversion pathways. That's why omega-3s are anti-inflammatory. But that pathway is hugely mediated by aspirin, interestingly enough. And so it's another place where aspirin is really beneficial, is in inflammation, not just as a sort of weak blood thinner, which is beneficial, but for inflammation because of that specialized pro-resolving mediator pathway. If you guys look up specialized pro-resolving mediators, you can buy them. You can spend a lot of money and buy specialized pro-resolving mediators, or you can just simply take your own by doing omegas and taking a little low-dose aspirin at night, a little baby aspirin at night. And I know aspirin's got a little bit of a bad rap through the years on, people with bleeding, things like that. So but at a very low dose, the safety profile is really quite good. And I think that the overall health benefits can be quite beneficial.
Yeah, he wrote a paper. I'm actually just looking. Ray Peat wrote a paper a while back about aspirin brain and cancer, and it's an interesting sort of read. It's long and it's in depth about it, but I've learned a little bit more about it because I've had some pro-metabolic individuals come into and talk on my podcast. What would you say, like, do you have like a ideal, I know everyone's different, but like an ideal supplement stack that for people, or I know it's hard to put like a generalizations on all this stuff, right?
So number one, I think one of the things we need to be careful of is over supplementation.
Yeah.
I think that we're getting a little bit, everybody hears the latest and greatest podcast pushing something, and I have people come in, I kid you not, probably on 120 supplements, right?
Oh, wow.
We have to particularly be careful with people who love their antioxidants.
Yeah.
Because antioxidants, everybody's like, okay, antioxidants are so good for us. Well, they're good and they're bad because we need oxidative stress. So if you go work out and then you run home and you take a bunch of your antioxidants, you're taking your vitamin C and your vitamin E, you've just actually undone all the benefits of your workout.
Sure.
Because what forms more muscle is oxidative stress. But that's true in our overall metabolic health in general. It's this very, very critical balance between reductive stress and oxidative stress. And we need oxidative stress to stimulate mitochondrial function, to stimulate health. Not too much. But if you are taking a bunch of antioxidants, you push it the other way. And now we don't heal and we don't recover, and we're in this reductive stress state, which actually can lead to cancers and other diseases. So I'm not a big fan of taking multiple antioxidants. And if you guys are taking your antioxidants, then cycle them. Don't do them continuously. Cycle on and off them so you give your body a little bit of time to recover. But our cells are really super, super smart, and we have to kind of support them in a more minimalistic fashion. I think it's a little bit like raising kids, right? You got to kind of guide them, but not push them, or everything falls apart. And so when I look at my basic stack, it's pretty simplistic, right? It's a D3 with K2. You need both of those together. Almost everybody needs magnesium. I think everybody needs omegas. Everybody needs probably a good B complex vitamin. And, and those sort of simple things go a long way. Now, do I take a whole lot more than that? Yes. But I cycle on and off of things, right? So, I will do things that are, I'll do Spermidine for a 6-week course. So Spermidine is an agent it's a polyphenol that really promotes autophagy. It really kills off our damaged cells. So you do a little higher dose of it for about a 6-week course. It's like cleaning house. So I'm going to do that for a 6-week course, clean everything out, right? And then you've got to look at mitochondrial function. We just talked about mitochondria as sort of the keys of everything because they're what control that whole reductive oxidative stress. So what I'm going to do for mitochondrial function, almost everybody could benefit from a little bit of like CoQ10 or PQQ, something that supports this mitochondrial electron change. Shane, you talked about methylene blue, but really the baselines are having enough iron, having enough CoQ10. Those are really important. Alpha ketoglutarate, important in that chain. Urolithin A is another one that can be really helpful for mitochondrial function. But again, these are things that can be cycled so you don't get overwhelmed with taking 50 supplements, right? When
Right.
I talk to like my staff of 30-year-olds or even my patients, one of the biggest complaints is I can't keep up with this regimen, right? So we have to simplify down these regimens. So what I do is I have a baseline stack of like 6 things I'm having people do. I make sure their hormones are optimized, and then we'll cycle them in and out of some of these other things. And that's where this becomes a little bit of an art because there is a lot of great stuff out there. And what I would encourage people is use it, but use it judiciously and spaced out and cycle between other things.
Yeah. No, that makes a lot of sense. I've probably cut back my supplements quite a bit through the years. I think, if you just focus on like the principles of like lifestyle, like we've talked already about strength training,
right?
Adequate protein, those will take care of 80 to 90% of
90%, right? And add to that the number one predictor, even higher than smoking, of your longevity is your socialization. It's having people around you, people who you do things with, and purpose. So, if you look at I'm actually giving a lecture next week on purpose at this lecture at this conference. And it's very interesting. When you look at people, when they retire, their likelihood of dying for every year of retirement goes up substantially. And, and I get people are all excited to retire, but the key is when you've lost some purpose, then there's something that goes on in our body that sort of says, you're kind of done, right? So our brain and our body connection. So you really have to have a social group of people, and you have to continue to have purpose because those actually go above everything we just talked about in terms of longevity. And, it's why when you look at these other countries who, everybody talks about these other countries like Sardinia and places who have longevity, one of the big things is they all have sort of community and they keep working. I mean, whether it's on the farms, whether it's in a store, whether they keep working well into their 90s. I mean, they don't stop working. So if you hate your job and you want to retire, I'm all for that, but find a new job, find something else to do, or raise your grandkids, or, do something, but it has to be purpose, and it has to be purpose outside of yourself. Like my people who said, I'm just going to drive around in my RV. It's what I've always wanted to do. That's great, but it actually doesn't have purpose. And so you need to also add something in there with purpose.
No, I love that you bring that up. I mean, I think like social isolation was one of the, like, that was the whole COVID thing that I think drove a lot of people.
That's what we do to old people, right?
Yeah.
I mean, my parents were lucky; they lived in their 90s, but they lived independently. They raised my kids. My kids were always over there because they knew them from the time they were babies and they were raised. And so they were interacting not just with, they'd go to the gym and be around older people there, but they were around us. They were around my kids. So they got all these different ages, and that was huge and probably made a big role of why they lived into their 90s, right? But what we do with a lot of older people is they've left the workforce. They're alone. They don't get out and socialize very much, and that's a big problem. We need to, the woman who works at my front desk is 80 years old. And she's amazing. Took her a while to catch her up on all the computer stuff, but she got it.
Right.
And she's probably my best employee because she loves working. She's so great with people. And why are we not utilizing this workforce? It's sad.
No, that's so true. It doesn't get talked about enough.
Right.
That's for sure. Why don't we touch on peptides a little bit? I know they're the hot craze. Are there certain ones that are like, your favorites and people that should look out for them, and there was other ones maybe that aren't as favorited? But
so I kind of like to think about peptides the same way I do hormones. So think about what does your body make when you're younger and you lose as you get older. Okay? Because we forget that our body makes peptides. So we have what are called endogenous peptides that our body makes, and they're designed to do very specific things. So for those guys who don't know a lot about peptides, they're just small chains of amino acids, right? Protein is more than 50 amino acids. A peptide is less than 50 amino acids. And they do very specific things. So insulin is a peptide. You eat glucose, insulin appears. It tells glucose to go into the cells. But we have other peptides. For instance, BPC 157, body protective compound 157. It's a peptide that's made by our gut. So it's a gastric peptide that's made in response to doing things like healing, not just our gut. So if we have irritation in the gut, it's designed to heal the gut. But also when it says, oh my God, he hurt himself, it's going to appear to go help heal that injury. When we're younger, we have very high levels of BPC 157. When we're older, we have much lower levels. If you've got problems, you have much lower levels. If you have chronic ulcer disease, you have much lower levels. So replacing BPC 157, just like you're replacing your hormones, right? If it's dropping, get it back up to where it was. And so we can use BPC 157 either post-injuries, where it's most used is if I have an injury to use it, but I will use it just ongoing off and on to try and keep levels a little bit higher. We know that if you have BPC 157 on board and you are hurt, you're less likely to have a problem with it. We know it's really protective to the brain. So if you have if you're an athlete who is in a sport that you're likely going to get hit in the head, then taking BPC 157 before that event is going to make the brain much more protected. So BPC 157 is a peptide that drops. Let's keep it up a little bit. And it can be taken orally. It's one of the few peptides that actually works orally. So it makes it simpler to take. So basically, you can even buy it as a supplement. Like at OHP Health has it. It's going to BPC as a supplement, and it's going to help the gut. If you guys, any of you guys who have chronic ulcer disease, things like that, those are all things that BPC can be really helpful for the gut. But think about it also for chronic joint pains, but also just think about it preventively. So that goes down. What else goes down? Growth hormone. So growth hormone drops as we age, invariably, just like all of your other hormones. It peaks around your 20s and then it starts dropping. And growth hormone is responsible for us being able to regenerate. So one of the reasons that, like, your doc may look at you and say, oh, you're really muscular, but you could still have low testosterone levels, is because your growth hormone in your 40s is still, it's not dropped, it's dropping, but it's not. So you'll see people have nice high IGF levels, growth hormone levels, and they look really muscular even though their testosterone levels are low. I have a friend in the bodybuilding world who is huge. I mean, he's massive. And he he's like, I feel like I have low testosterone, which, and anybody who looked at it was, there's no way you have low testosterone.
Right.
You're massive. But it was because his IGF levels, which is a measure of growth hormone, were so high that it masked his testosterone of 200, right? He was still able to put on muscle despite this low testosterone, which was affecting his brain, his libido, and everything else. So, but growth hormone levels do drop as we age, and growth hormone is really important for regeneration. It's really important for sleep. So what we do is, growth hormone itself has a problem in that it gives you a super physiologic dose of growth hormone. So the way growth hormone works is it converts into IGF, insulin-like growth factor. IGF has these receptors on immune cells, on brain cells, on muscle cells. And so we can measure IGF levels. If they're low, we can give peptides that will make your own production increase. So instead of just giving you growth hormone, which is going to be like, giving you too much and then it'll drop down, you basically give peptides, and usually use things called either CJC and ipamorelin or tesamorelin and ipamorelin. We use a combination of peptides that tells your own pituitary to both make and release a little more growth hormone. So now we're going to get really physiologic levels of growth hormone, but bring it up kind of where your body wants it to be, as opposed to hitting it really hard. Because if you look at, remember the old bodybuilders, how you look at those kind of turtle bellies, or the bellies that sort of stick out like this. You can see the muscle, but their bellies would stick out. The reason that would be is because their organs grew from taking so much growth hormone. So they actually got their spleens and livers grew from taking so much growth hormone. So we don't want that. So you have to be careful with growth hormone. There's places for it, but you have to be careful with it. But the growth hormone secretagogues can be utilized either on and off, like 3 months on cycles, or just 5 out of 7 days of the week continuously to keep my growth hormone levels up, just like I'm keeping my estrogen up and my testosterone up and my progesterone levels up, right? So again, and then what other peptides drop as we age? So the other big peptides are thymic peptides. So when we're babies, we have this giant gland in our chest. This is huge gland, it's our thymus gland. It's why when we're little, and that thymus gland keeps getting bigger until puberty, and then starts shrinking. When you're old like me, it's nothing. It's a little fatty nub, it's not doing anything. So the thymus gland early on is designed to be our immune gland. It's telling the body, attack that, it's bad. Don't attack that, it's good. So when it starts to decline, our immune system starts to get screwed up. It starts to not recognize bad from good. It starts attacking itself more, attacking viruses less. So if we can keep the thymic peptides a little higher, so we can't give you a new thymus gland yet. Maybe eventually we will. People like in France that eat sweetbreads, which is thymus gland. Maybe that works a little bit. I don't know. But we can give the things that thymus gland does. So it makes 2 peptides, one called thymosin alpha-1 and one called thymosin beta-4, that you can utilize sort of on and off, again, to try and keep my thymus levels where they would have been when I was young. So again, BPC, the growth hormone secretagogues, the thymic peptides, those are kind of your baseline sort of, okay, those are going to, and then the last, and this is getting a little more intricate, is in all of us, as we age, our mitochondrial function declines. It's why we have less energy. It's like why you look at a 5-year-old running around going, oh my God, I wish I had that energy, right? Because they have massive mitochondrial function going on. And that declines as we age. It declines because of bad things like COVID and viruses and stress. So the less our mitochondria are working, the less energy I have. Any of you guys who have poor energy, who have brain fog, that's mitochondrial dysfunction. So the way the mitochondria respond to being stressed is they make their own peptides. So they have their own little peptides, something called MOD-SC, SS31, human, and they make their own little peptides, right?
Did you say MOD?
Yeah, it's MOT-SC, MOTS-C. So MOT-SC. SS31, these are peptides that the mitochondria make. So again, these are not some foreign thing to us. So I think people think about peptides as some foreign thing, these are things that our body makes. So if my mitochondria are suffering and I don't have enough mitochondria anymore, they're designed to send out this stress signal, to send out this MOD-SC, to send out SS31 and say, hey, let's make our mitochondria better and stronger. But as that function declines too much, they can't. Right? They just can't respond. So we can give back some of the mitochondrial peptides periodically, particularly MOD-SC, which helps metabolic function. It's going to be revving up the mitochondria. They're just going to make ATP faster. So we can do things like that on and off. Or if you have a specific problem, like you're having horrible brain fog, or you're getting over COVID and you feel like you can't get your energy back, then you can actually hit with MOD-SC. So those are kind of my top peptides in my sort of longevity realm,
Do
right?
I'm sorry to interrupt you. Do you like if you have a client, do you test them or do you sort of, or how do you go
So
about
mitochondrial
looking?
function is hard to test,
Yeah, I
right?
was
We can
gonna
look at
say,
things like
yeah.
lactate pyruvate ratios. We actually do what's called a prodrome scan. It's a scan designed by Dr. Dane Goodenow that looks at ratios of cell membrane components that you can sort of give some hints about mitochondrial and peroxisomal function. So there are tests that help, but we don't really have a great test to say,
Right.
oh, this is exactly how your mitochondria function. So I think you have to kind of go on, if you have low energy and you have brain fog, that's probably, and you fixed everything else, the hormones look good, everything else looks good, then
That
you have
could
to
be.
focus on the mitochondria.
And with peptides, do you like, let's just say someone wants to look into, I don't know, the BPC 157. Are there certain places that, that are better to get them from than others, or?
Well, so BPC is a little different story because again, it's sort of been moved into almost the supplement category because it's
Okay.
so incredibly safe. Like you can't really ever take too much BPC. So it's now available. Like if you look, on a lot of places, it's available as an oral supplement. Now,
Okay.
most peptides are injectable
Yeah.
and they need to be done confidently in what is the proper dosing, what is the proper timing. So I do think you need to work with somebody who knows peptides. What's happening in the peptide world is that it's becoming huge and everybody's jumping on the peptide bandwagon. So you can buy peptides online from any research chemical site. The problem with that is you don't honestly know what's in them. So when a compounding pharmacy makes a peptide, so this is an FDA approved compounding pharmacy that has to go through rigorous testing. They have to prove a lot of things about the facility, about the products they're making, and keep a very close eye on it. So if I decide to go just buy my peptide from a research chemical site who has not had to do any of that, number one, if there's a complication, they have nothing to stand on. They're not, they didn't even tell you to use it. It's a research chemical, right? And
Right.
we've had research chemical peptides tested. Some have what they say in them, some don't. Some have a lot of contaminants in them, including arsenic. Some don't. So you kind of don't know what you're getting.
Mm.
So that's where the problem in this world of cancer was just a big thing that happened at RadFest. Some of you guys may have read about this. RadFest is a big longevity conference, and there was a doc there doing peptide injections in the exhibit hall with a research grade peptide. 30 people who got this injection got really sick, ended up in the hospital, two of them on ventilators, right?
Wow.
And he can't really even go back because he doesn't have a pharmacy to stand by to say, oh, okay, let's look back at that lot. Let's make sure it was okay. He doesn't even have that to stand by. So
Mm.
we can't even look back and say what was in that peptide that they were given, because it came from who knows where, and we don't have any lot numbers. So honestly, I know that this is controversial, but you should be getting your peptides from a compounding pharmacy, and from somebody who really knows exactly how to use them appropriately and has been trained in them. And I know it's controversial because now everybody's like, you don't need a doctor. It's much more expensive to do that. You can read about this online. You can get them from your research facility. And this is not, guys, just because I'm trying to promote that the doctors should be making money, but it really is. I've seen a lot of bad things happen. I saw a guy end up in the ICU from taking, multiple research peptides. I've seen bad things happen. You just have to be really careful.
Mm.
For me, I would never take a research peptide because honestly, if something bad happens, who do I go to? At least now, so if one of my patients gets sick from a peptide I gave them, I'm going to go back to that pharmacist and I go, hey, you need to look at that. What was in that peptide? Was it, and they can backtrack and retest batches and say, oh, we found a contaminant, we found something. This happened in the drug world too, right? Think of the number of drugs that get recalled
Oh, sure.
because somebody got sick and now they went back and looked at it, but they recalled the drug. Well, we need to be able to do that, right? We need to be able to backtrack. So that's my bias. Get them from compounding pharmacies, from people who know what they're doing.
Yeah. No, that's great advice. I would agree. I mean, the supplement, right, I know these, with the peptides, it could be the wild, wild west a little bit out there right now.
Right.
People selling them that shouldn't be. Well, this was great. We'll finish with this one question that I like to ask most of my guests that come on. What's like one thing that you've changed your mind on?
Boy, there's a lot that I've changed my mind
Sure.
on, but probably where I'm kind of getting a little bit more questioning is rapamycin. So I used to put everybody on rapamycin. Rapamycin, for those guys who don't know, is probably one of the big compounds that we're saying this could be really the answer for longevity, right? And And I still think it might be, but what I'm finding is maybe we don't know enough. I'm seeing people who I've had on it who have lipid problems, who have glucose problems, and I still would say it's a good drug, except I think we have better longevity agents now. For instance, the GLP-1 agonists, the semaglutides and tirzepatides, those drugs are so huge for longevity. They're affecting the same pathways that you're doing with rapamycin, except doing it in a much safer way. So I think we've had drugs that now have surpassed rapamycin and become better choices, safer choices until we know more. With the exception, I will use rapamycin in my younger women who are trying to delay having kids, like they're 35 and they haven't met a guy yet, because we do know it protects ovarian function. So I will put them on rapamycin, low dose rapamycin, because it will protect ovarian function in that group. But otherwise, I'm not putting every one of my patients on it anymore. I'm using other things. So I really, and rapamycin is still huge in the longevity world. And I'm not going to say it's bad. I just think we don't know yet. And now, and I'm okay with not being sure, but now we have better options potentially to use.
Okay. Yeah. That's the first time that answer has been given. Well, this was great. Dr. Yurth, the Boulder Longevity Institute, best place for people to find you is your website?
Yep, just boulderlongevity.com. Follow me at Dr. Yurth. We have, for you guys who want, we have a teaching academy called Human Optimization Academy, because one of my beliefs is it's hard to find doctors who know enough, so you got to know a lot. So, people like you, Brian, out there teaching is great. But this is a site where you can go, how do I read labs? How do I, understand hormones? So it's designed for lay people to sort of get doctor training, hopefully better than your doctor. And so you can sign up for him. If you go to bli.academy, you can look at that. We have these monthly Q&As that people ask incredible questions that, blow my mind sometimes. So, and there's doctors in that too, but there's just a lot of lay people who are just interested in their own health so they can learn. And there's courses on, understanding peptides and understanding hormones, and that you can go and just learn more. You just have to be empowered on your own, because it is hard to find good doctors, and the more knowledge base you have, the better off you are. I mean, AI, and I know doctors hate AI, but AI is huge, right? I mean, you can do so much with putting your symptoms in AI. And then you need somebody to, and AI will spit out all these, 15,000 things you need to do. And then you need somebody to maybe help bring it in. So I encourage people to use AI. It's fine. AI is very smart at a lot of things. And so you can put your whole symptomatology in, and it will say these things. You may still need somebody to help refine that a little bit more. You still need to be able to kind of look at your hormones in a little different way than AI might. So I think that use AI, but go really empower yourself to learn.
Yeah. No, I love that you have an institute. Is that the Dr. Scott Scher? Did he go to? Is that his same institute that he has?
No, they have a different. They have a different thing called Home Hope.
Yes,
it's a little different. Okay. I think it's a little bit more health coach designed, and not just quite so much lay people designed.
Okay, Human Optimization Institute.
Yeah, Academy. HOA.
Okay.
So yeah, bli.academy is the site to go for that.
Okay.
And then BoulderLongevityInstitute.com, just for looking at our things. And we're in Boulder, but I'm licensed in every state, so we treat people all over.
Okay, so you do like telehealth?
We do telehealth, yeah, and orthopedic stuff too. We can do a whole lot, even from a telehealth perspective. If you send us your imaging, talking about your symptoms. Obviously, if you need procedures, we'd have to have you come out, but there's a lot we can do online for people too.
That's great.
Like Pentacin.
Yeah. Okay. All right, Dr. Yurth, I appreciate you coming on. This was great.
I appreciate you letting me come on. So nice.
Have a great rest of the day, and thank you.
Thank you.
Thanks for listening to the show. I know there's thousands of podcasts out there, and you chose to listen to mine. I will put a link in the show notes if you want to connect with my guest. And if you are looking for one-on-one consulting with me, I will put a free 15-minute link so you can set up a call to see if you're fit for my 6-month health breakthrough program. So thanks again. Feel free to rate and subscribe. I would love that to help support the podcast. And till next time, have a great rest of the day, and I will see you on my next podcast. Thanks so much.